Schizophrenia is a chronic brain disorder affecting around 1% of the Australian population. Active schizophrenia includes symptoms of delusions, paranoia, trouble thinking, and motivation problems. There are three categories of symptoms of schizophrenia. These are positive symptoms, negative symptoms, and disorganized symptoms. Whilst the word positive would suggest to those that are none the wiser that these symptoms increase the well-being of the individual, this is not the case. Positive in this case refers to the symptoms of schizophrenia that are present for the individual but abnormal for the general population. Positive symptoms of schizophrenia include paranoia, hallucinations, and distorted perceptions and beliefs and behaviors. On the flip side, negative symptoms are those which the general population would exhibit that are decreased or absent in individuals with schizophrenia. Negative symptoms of schizophrenia can include a decreased ability to experience and or express emotions, initiate or partake in social activities and workplace responsibilities, and in some cases, a decrease or complete loss of verbal communication. The disorganized symptoms of schizophrenia are confused and disordered speech and cognition, and sometimes abnormal movements and behaviors. Transcranial direct current stimulation, or tDCS for short, is a brain stimulation method which is gaining popularity as of recent. During tDCS, two electrodes are usually placed on the scalp of the participant or patient. In the traditional method, only one of the electrodes is targeted, whilst the other is used for reference sake. This is called the unihemispheric setup. A bihemispheric setup may also be used, in which case both electrodes are target electrodes, each targeting parallel cortices, upregulating or increasing the activity of one region of the brain, while simultaneously downregulating or decreasing the activity of another through anodal and cathodal stimulation. A weak electrical current, typically 1 to 2 milliamperes, passes between the two electrodes, passing through the brain to complete the circuit. Anodal stimulation depolarizes the neurons, which increases the probability of action potentials occurring, whereas cathodal stimulation hyperpolarizes the neurons, which in turn decreases the probability of action potentials. Now on to why you're actually watching this video. How has transcranial direct current stimulation, tDCS, been used to treat schizophrenia? The current primary treatment for schizophrenia is antipsychotic medications which, whilst being a step forward from lobotomies, has limited efficacy in treating many negative and disorganized symptoms. Some studies find that even after personalized optimization of antipsychotic treatment, 20 to 30% of individuals will experience only partial or even no response. Researchers began experimenting with using repetitive transcranial magnetic stimulation, or rTMS for short, to treat individuals presenting with schizophrenia. Though many studies showed efficacy in this approach's ability to reduce the severity of positive and negative symptoms in patients, current guidelines do not suggest rTMS be used. Enter tDCS. tDCS is a less invasive and cheaper method of transcranial stimulation than rTMS is. However, it has yielded mixed results in experimental and clinical use of treating the symptoms of schizophrenia. The first randomized control trial of tDCS in schizophrenia patients, referenced here, reported a statistically significant decrease in the severity of auditory hallucinations, lasting up to 3 months post-stimulation. However promising this initial study seemed to researchers, results of following open-label trials, which are trials in which no information is withheld from participants, and sham-controlled trials, trials in which the placebo effect is used to determine effectiveness of treatment, have been very inconsistent. This is likely due to changes in tDCS methods used across separate studies. Another recent meta-analysis in 2019, full list of contributors in description below, analyzed 10 trials of tDCS. This meta-analysis recorded the following variables: demography, including sex, age at onset of illness, illness duration, baseline severity of symptoms, and antipsychotic drug taken, as well as dosage of said antipsychotic drug. The outcome measures recorded were the severity of positive and negative symptoms, both baseline and post-tDCS. Depressive symptoms are also often reported alongside negative symptoms of schizophrenia, and as such, a separate analysis was performed for these depressive symptoms. The 10 chosen studies were all similar in methods and tested variables. However, there were some notable differences in the parameters for participant inclusion. All of the studies included a requirement of a schizophrenia diagnosis. However, 4 studies also included participants with a diagnosis of schizoaffective disorder. Some studies required that the participants had exhibited either positive or negative symptoms, some specifically named, for specified periods of time. Another key difference between studies is the placement of the electrodes on the scalp. 6 of the studies included a frontoparietal placement and 4 included a bifrontal placement. The number of total sessions ranged between 5 and 15. 7 of the 10 studies were included in the analysis of the severity of auditory hallucinations, of which no main effect of tDCS was found. 9 studies were included in the analysis of positive symptom severity, of which there was also no main effect of tDCS found. There was, however, an effect of the tDCS parameter of a frequency of treatment, either once or twice per day. There was no effect of the electrode placement on the severity of positive symptoms. 9 studies were included in the analysis of negative symptom severity. Again, there was no main effect of tDCS, however there was an effect reported of the amount of sessions. There was a significant decrease in negative symptoms for those who had 10 sessions or over. There was also no main effect of tDCS found for the analysis of depressive symptoms, of which 5 studies were included. Future research should center on the frequency of tDCS, whether once or twice daily, and the total number of sessions, as these were the only factors found to decrease any symptoms. Severity of auditory hallucinations were the only positive symptoms to be significantly affected in the entirety of the meta-analysis, and the severity of negative symptoms was not directly affected by tDCS, only impacted by the total number of sessions. Due to this, future research could also have a honed focus towards positive and disorganized symptoms, as there was little found effect of tDCS on the majority of positive symptoms, and the disorganized symptoms were not directly analyzed in this meta-analysis at all.